The screen is okay, yes?
Yep. Fine, Konovalov.
Yes, let me turn this on. Okay, good. So my topic was discectomy and fusion for recurrent disc herniation. So what to do if you have recurrence, do only micro discectomy or to do the fusion? First of all, I want to thank you, Dr. Stanislav Kaprawy, who hosts me for preparing this lecture. And so recurrent lumbar disc herniation is one of the major cause of failure for primary surgery. Treatment for recurrent lumbar disc herniation remain a very hot topic. Concurrent evidence for the instrumented spinal fusion with repair discectomy is lacking. In a literature review on PubMed over the last 10 years, we find 6 most important articles who is comparing only decompression and decompression with the fusion as a treatment method. So there is this. So I'm going to share you the information about 6 articles. Here is the first 3 articles. First one was by Dr. Dovell and co-authors. It was published in 2016. The name of it, Surgical Management of Recurrent Lumbar Disc Herniation and the Role of Fusion. It was published in a Journal of Clinical Neuroscience. It was designed by like a systematic review. Methodology was Prisma, and it includes 37 studies. So, they assess the effectiveness of repeat discectomy alone versus instrumented spinal fusion and repeat discectomy for the management of the recurrent lumbar disc herniation. And in conclusions, they have that overall results demonstrate no benefit from spinal fusion. Satisfactory clinical outcomes were significantly similar. So the second paper that we mentioned, was printed in 2017 by Dr. Onur and co-authors, and it was the name of Debates on Most Ideal Technique for Managing a Recurrent Lumbar Disc Herniation, a short review, and it was published in the British Journal of Neurosurgery. It was systematic review. It was Prisma plus Robinson 1, and it was 10 studies were included in it. And the idea was to compare the available operative options for the recurrent disc herniation to determine if any of the available interventions gives better outcomes comparing to others. The subgroups was decompression. There's decompression with fusion, and in conclusions they said the fusion should only be considered as an option for the revision when spinal instability and spinal deformity is clearly demonstrated. The third paper, which is important for us, it was published in 2018 by Dr. Kerisodis and co-authors, and the name of this paper was Comparing Outcomes of Fusion versus Repeat Discectomy for the Recurrent Lumbar Disc Herniation, Systematic Review and Meta-Analysis. It was published in Clinical Neurology and Neurosurgery. It was systematic review and meta-analysis. The methodology was Prisma and GRADE, and 15 studies were included in it. And the idea of this paper was compare reparation on the rates and patients' reported outcomes following fusion versus repeated discectomy for the recurrent lumbar disc herniations. And in conclusions, we can find out that available evidence shows that treating a recurrent lumbar disc herniation, repeated discectomy, and fusion are associated with comparable reoperation rates, including the durature, functional outcomes, and as well as the patient satisfaction. So all of these papers, like as a second one, which was printed by Dr. Tanaval in 2019, shows that there is no difference between decompression and fusion. So Dr. Konovalov in 2019 and co-authors make a paper, a comparison between repeated discectomy versus fusion for the treatment of recurrent lumbar disc herniation, systematic review and meta-analysis. It was published in the Journal of Clinical Neuroscience. It was systematic review and meta-analysis. The methodology was PRISMA. Only 4 studies were included in this meta-analysis. And the idea was to compare reparation rates between repeated discectomy and fusion treatment for the recurrent lumbar disc herniation. So conclusions was no difference in the reoperation rate between the 2 surgical treatment was found. Both treatment techniques have equal improvement rates and complications. One more paper was by Dr. Arif and co-authors published in 2020. Is fusion the most suitable treatment options for the recurrent lumbar disc herniation? A systematic review. It was published in Neurological Research, Journal of Neurological Research. Research. It was a systematic review, and methodology was PRISMA, and includes 16 studies. And the idea was to evaluate surgical management of recurrent lumbar disc herniation between different surgical treatment methods, including decompression and decompression with fusion. And the conclusions was about the same, the significant heterogeneity in the reported studies. Neither discectomy nor fusion's superiority was significantly significant. Choice should be based on the case-by-case basics. And so all of these 5 studies shows us that there is any benefit of doing the fusion in the recurrent disc herniation, and only one study which was published this year, 2023, by Dr. Lee and co-authors. It was spinal fusion versus repeat discectomy for the recurrent lumbar disc herniation, a systematic review and meta-analysis. It was published in World of Neurosurgery. It was systematic review, Newcastle, Ottawa. The design of methodology was PRISMA. It includes only 11 studies. The idea was to compare the effectiveness of spinal fusion comparing with the repeat discectomy in the treatment of recurrent lumbar disc herniations, and their conclusions was that pooled evidence suggests that spinal fusion achieves better results than repeat discectomy for recurrent lumbar disc herniations. So we can conclude that in the most important papers that was published about which is better for recurrent disc herniations, which is only microdiscectomy or the microdiscectomy comparing with the fusion. 5 papers said that there's no difference between this, so you can do the microdiscectomy and you don't need the fusion. And only 1 paper said that the fusion is better. So we can say that our idea is that recurrent lumbar disc herniation is not a medical error, but it's a natural cause of the disease. So it's just, and so you have to, maybe you have to treat the recurrent disc herniation in the same way as you treat the primary disc herniation. Primary surgery for lumbar disc herniation should include throat review of epidural space and, if necessary, the revision of the disc space to remove all pieces of the disc that can give a possibility of the recurrent. The recurrent lumbar disc herniation should be treated with a repeated discectomy unless there are clearance and the finding for the spinal instability. So if you, for our ideas, when we can do fusion for in our clinic for recurrent disc herniation, when we can see that there is a spondylolisthesis more than 10 millimeters, or that there is a pathological mobility on the functional spondylograms. And also we mentioned that if these signs like the angle of the intervertebral joints is more than 50 degrees, there is a high disc and there is a more back pain in the neurological status, or there was a laminectomy used for the first removal of disc herniation, or the high pelvic incidence. If we see a lot of these signs, then we think about if fusion is necessary. But in each case, we take very personally ideas to fuse or not to fuse. But in real life, it's less and less cases when we do fusion for recurrent disc herniations. So thank you very much. So don't stress and decompress. Thank you.
Thank you. Yeah. Thank you very much. Very nice talk, Dr. Konovalov. And now we have some discussion time. All the four speakers have summarized their part perfectly. Like it started from, if you take it from Sandeep, and Sandeep has said very clearly about the factors which are affecting, factors which are influencing the recurrence of recurrent disc herniation. And then we had Ruli talking about what should be done, what can be expected intra and post of the recurrent disc herniation. And of course, that we had Andrea who were talking about three articles which he summarized, finally saying that discectomy first, and if needed fusion, because still the world is balancing towards. And in concluding with Konovalov has made extremely fantastic paper saying out of the five big articles, that is the fifth one is his one, that 4-1, the 3-1 which is supported, there is not much of difference between this or that, but then the last one supported more of the fusion. I personally feel that this particularly recurrent disc herniation management goes well with our maturity goals in lumbar spine surgery. From the time we start doing the lumbar spine surgery, and then from the time we start seeing the recurrent disc prolapses, so our views changes. Now, my point with the Konovalov's talk was extremely good. The reason for that is finally he made one last slide that don't get excited first, to decompress first. And if you have one single sign of instability, one single sign, he has quoted about 5 points. If you have one sign of instability, then you go ahead with doing the fusion. I'm talking about when a patient comes for the first time. Now, I like to put forward a simple question to all the speakers, all the four people, all the four. With your personal view, after seeing the literature, when will you like to consider fusion? At what point in time? That is, when the patient comes to you first time, or if the patient has done 2 surgeries already, discectomy, or 3, or when? When will you be considering the fusion finally? I think.
Can I speak first?
Yes.
So normally I would do a minimally invasive procedure the first time if there is a recurrence. And I don't agree with Ruli when he said that during recurrence, one has to do an open procedure. We always do a minimally invasive procedure, and that is done quite well without any significant increase in the risk or complications. But if patient has a recurrence second time, then that is a very difficult question because no patient really wants a third time surgery. So perhaps in those patients, I may do a fusion.
Okay,
but but if you fuse the level, then you're going to have adjacent segment disease. So it doesn't stop. For me, I would do only microdiscectomies for all recurrent disc herniation, if it happens one, I do microdiscectomy. It happens the second time. Finally, we remove all the disc, and then there may be a fusion between two vertebrae but not when using the spinal screws, the transpedicular screws. And for me, it's better to keep the spine without any implants, because if you put the implants in 5 years or 7 years, they will come back with the stenosis or the adjacent level disease. So for my idea is there's no place for fusion if you don't see real instability on X-rays, or there is a spondylolisthesis, even grade 1. If it's small spondylolisthesis, you can think that is better also not to fuse it. So in severe case of instability, then we think about the fusion. But in other cases, we continue to do microdiscectomies.
Mehmet, you like to make any comment?
Yeah, I want to show you one slide only. I am sharing my screen. This is this slide. As you see here, if it is an ipsilateral disc herniation, we can look at some instability signs or some other factors, clinical factors. If it's from contralateral side, just discectomy. But my policy is like Sandeep has said, if it's a second recurrence, I mean, it is then the third surgery for patient, I suggest always a fusion surgery. Always. But if it is ipsilateral recurrent, then severe back pain, if there is severe back pain attacks after first surgery, if there are severe modic changes, additional stenosis, and this kind is still preserved, then I suggest fusion. But if the disc height decreased, only sciatic pain and long duration after first surgery, then discectomy alone is more logical. These are my my policy, but it is not very evidence-based. There are some evidence-based points of it, but not all of it, I must tell. Thank you.
I understand. So the point what Mehmet trying to say is that more of a biomechanical stress. If biomechanical stress is more, the points which we made on the left side corner all comes in. That's where you go in for a fusion. And if the biomechanically the stress is very less, where you have good only a disc prolapse and radiculopathy, you go in for a second discectomy. That's all. So that's a very nice division of thoughts. I wanted to ask Dr. Ruli, you made a very nice point. Surgery which you think better may not be better for the patient. Sometimes the patient thinks the other way. Now, Ruli, you made another good point that the second surgery must be wider. This is where Sandeep was differing from you. Sandeep would like to do from
No. Wider is a different thing than doing an open surgery. Even with minimally invasive surgery, see, when there is a recurrence, you always have to go a bit wider. You have to do more first joint removal to reach the normal area and then dissect out from there. But what Ruli said that vertically also more, I don't think that is required in most of the cases.
Yeah. Ruli, would you like to answer this? This point, because what he is telling is that he can do the same thing through the minimally invasive approach, like a tubular retractor, without doing much. But what did you mean by wider? Did you mean by wider?
I mean, if the first, I agree. Actually, I agree also with Sandeep. But if the first surgery is already open surgery, discectomy with open surgery, he said the second one should be wider than that. So if we can do the second discectomy for recurrence with MIS endoscopy, it must be the first surgery also by endoscopy. if the first surgery by open surgery, we cannot do smaller at the second surgery. That's what I mean. So I will do also MISS for the second recurrence in as long as the first surgery also MISS. If it's not MISS at the first time, we cannot do that because we need to open wider and see the pathologic structure after the first surgery.
Thank you.
Again, really, we get several patients who have been operated before by open procedure and have a recurrence, but we do MIS the second time when we do it. I don't think that should be a problem.
Yeah, I have the same idea. Yeah. One thing, Jutty, we must also answer the written questions from the chat box.
I'm going to that. I just saw the chat box. I would like to, sorry, I wanted to go to the chat box, and this is a very important one which Dr. Ahmed et al. Have asked, that how much disc will you be removing, the herniated fragment alone, or open the annulus and scoop it out completely inside to reduce the recurrence? Because this is an important question everyone asks. Most of the people ask about this, and I'm certainly sure that this will correlate with the grading of the disc degeneration. I think I would like the experts, the speakers would like to answer on this. How much disc will you be removing when you see for the first time? And when you see for the second time, how much will you remove it? Sandeep, would you like to answer?
Yeah. So the first time, I normally remove whatever the part is herniated, of course, and then I go inside the annulus and remove all the loose fragments and then wash it out. And suppose if I have to do it second time, then perhaps I would be more radical and try to remove whatever I can.
Konovalov, would you like to?
Yes, okay. For the first time, if we see sequester and we don't see any damage of the annulus fibrosus, and we remove only sequester. If we see the damage of annulus fibrosus, then we take the smallest instrument and go inside it. Don't enlarge it, and try to remove as what is possible. But if we go for the but we try to keep the disc if it's still okay. For the second time, we're really more aggressive to remove as much as possible from the disc to prevent more new herniations.
Ruli, would you like to say?
For first time, we try to keep the disc alive, but we try to remove all the parts that can go immediately after the surgery. For the second time, we're more aggressive. Yes.
Okay. Ruli, Dr. Ruli.
Yeah, I agree. Yeah, pardon. The question is about the second time. I'm sorry.
Yeah, the first time and the second time. See, the first time, how much will you like to remove it? And when you get the patient for the first recurrence, that is the second time, how will you deal that?
Yeah, the first surgery will be redo the discectomy for me. If the MRI proof the pathology only on the disc itself, but if it's happened another pathology like adjacent segment syndrome, malalignment, and spondylosis is developing more than 2 level, I would suggest open wider the compression and put fusion directly, even in the first surgery. So it's depend on the MRI. So if the MRI and the LSR test confirm it's only reherniated of the same level, like the definition, so I will do another redo the discectomy at the same level, but with a wider opening, because I have some bad experience about doing endoscopy and minimal invasive for the second surgery. It's the patient is not satisfied after surgery. It's still pain after the second surgery. So maybe it's because my personal experience, I decide if the pathology is not good, it's not only recurrence, I mean, it's another pathology there, so I will do more aggressively, even at the second surgery.
Okay. I'm going through the chat box, and I think there were some questions answered by Mehmet about these modic changes. Some of the questions came with the modic changes. Is the modic changes primarily something else, or it is due to the disc degeneration and due to the biomechanical stress? So does the modic change also indicates that this patient will certainly do get a recurrence or not? So that is the important point which is coming here. Now,
Yeah. As I
Yeah.
know, there is a close relationship with the modic changes and recurrence rates. There is. This is
There
a
is.
kind of instability. If there is additional disc height preservation and some movement during flexion extension films, in those cases, if recurs, should better be undergone to fusion surgery. This is what I'm telling from the literature. Literature also says modic changes has good relation with the recurrence. But there is one question which is very important question that is San Francis asking if we have to aggressively remove the disc to prevent recurrences. There is no good correlation for that, as I see.
Now,
aggressive removal is not necessary, I mean.
The point I would like to re-ask Sandeep and would like to get something from him is, do you like to compare in the modic changes with the high grade of disc degeneration, or the 7th and 8th grades, or 6th and 7th, 8th grades?
See, if
do
so,
they have any correlation? Like, this is a more of the scientific question, because why it is important is in the speech when you made it that the grade 3, 4, 5, they do recur more than the 1 and the 7 and 8. Am I correct?
Yeah, so because in 1 and 2 the degeneration is quite minimal, and 7 and 8 the disc height is not there, it is completely degenerated, so the risk of recurrence is less in those patients.
So do we have any correlation with this and the modic changes?
So again, though there is no correlation between modic changes and the degeneration of the disc as such, as far as I could find in the literature. But if there is significant degeneration along with modic changes and significant back pain, then I think that would be a good candidate for fusion.
Okay. The other questions in chat box is a very basic question asked for from Bulgaria. Dr. Edwin Vaspi has asked, he has asked some basic question: when will you operate on the disc prolapses? Would you like to give the first conservative treatment, or you go away for surgical management immediately without any conservative treatment? It's a very basic question, though it is not coming for the recurrent disc, but it is a basic question. But I would like the panelists to answer for at least for him, also for the young people who are now watching us.
As I mentioned already, I think the treatment of the recurrent disc herniation is the same of like a primary disc herniation. So you surely have to do the conservative treatment for the beginning, like for 4 weeks, or a little bit less or a little bit more. If you see that the pain is still strong and there is no, if the patient is not coming better, then think about the surgery. But the conservative treatment is surely at the beginning. But in the case of a strong paralysis, or in the case of caudic venous syndrome, then you have to go surgery as fast as possible.
Mehmet?
Yes, and I totally agree with Nikolay. I have also answered that question on the chat box. Yeah, we must first try conservative treatment. If it doesn't give any benefit, we can ask for surgery.
Now, No, I put forward the last discussion because we are already running short time. We have over exceeded now. We are more than about 1 hour and 40 minutes. At least I think we are there. Would like to know about the recurrence of the disc. At what time the recurrence is quite common? See, for example, some patients do come in about 15 days or in less than a month period time. We have seen cases which are coming. But in all these patients, if you ask them one particular point which they tell, why they get this, why get the pain, and they always say that they have gone through a very stressful act. For example, the acts like, fast moving, jumping from one place to another place, and then getting into the car and getting out quite often. So what, do you have any experience on this type of the early disc recurrence in lumbar after discectomy? Nikolay. Nikolay?
Me?
I asked,
So-
yeah. I would just
so-
try to get
So
your opinion.
we ask the patients to keep some restrictions for 2 weeks after the surgery. So 2 weeks after the surgery, be accurate and don't do big stress on the spine. So I think this is the way how we can prevent the early recurrent of the disc. But it's these things happens, and I think it's no normal thing, because if we try to keep the disc alive, so there is some parts that is not reachable during the surgery, and if there is a recurrent disc herniation, it just shows us that we have to remove more part of the disc. So I think there's no mistakes in the surgery when we see a recurrency. It's not a mistake of the surgeon, because if right after the surgery the pain is gone, but after the activization of the patient and when he returned to normal life, we see the parts of the disc go out and make the pain. So then we think that, and there's no way of, there's no benefit from the conservative treatment. Then we can say that we have to do another surgery and be, I think, more aggressive at try to remove more parts of the discs. But for us, we still, the fusion is, we try to avoid it. If there is no symptoms of instability.
Basically, they are more enthusiastic patients who get well after the pain is gone, and they try to do more stressful act in the first month itself. But I have come across few cases, so I just wanted to get opinion from the other specialists, and Konovalov made it very clear on that point.
Jutty, I operated a lady last year for a recurrence. She was a female bodybuilder. And 1 year after, like the recurrence was about a year after the first surgery, and she was doing leg press with 140 kgs. And so that's when her disc suddenly snapped. So you are asking for it. So,
but for example, I suggest when the people do the weightlifting or something, if they have a disc herniation, we already see the problem in the discs, and the disc herniation can be happened even on another level of the lumbar spine. So my suggestion for all the patients, if they have a disc herniation and not to should continue the really stress on the spine, especially like you told, the weightlifting was 140 kilos. This is my idea.
Can we possibly ask Yahya, is one of our faculty, about his policy for recurrences?
Yes.
Oh, is there? Okay. Yeah.
I agree with Nikolay. We are the same. We are making microdiscectomy again for second disc herniation. If there is instability, we use fusion. But if there is a modic change and there is a foraminal stenosis, we can use lumbar fusion for after second operation, for third operations.
And can we ask Onur? Onur is also with us.
Onur is there?
Onur has disappeared.
Yeah,
No, he's not here.
Onur is not there. And is there
Okay.
anyone who would like to say something about whatever we have discussed? Because today we have a very nice attendance of very young neurosurgeons from all over the world. And because of the excellent topic chosen by Yahya and Mehmet and Onur. And I'm very happy. Thank you for giving me this opportunity to moderate. And I also thank all the speakers. I would like to hand over to Yahya and Mehmet. Thank you.
And
Okay.
for closings.
Yeah.
Yep.
Thank you a lot for all of the speakers for their very nice explanations, and also all the participants from all over the world. Wish to see you again in our next webinar. Goodbye, everybody.
Thank you very much.
अभी खत्म हो रही है 5 मिनट बात कर लेना
Thank you all.